Good morning, everyone, and thanks for inviting me to this inaugural Global Cardiovascular Forum. I'm Dr. Srikanth Koneru. I'm the Director of the Structural Heart Imaging and Valve Clinic and the Interim Director of the Cardiovascular CT/MRI at Texas Heart Institute at Baylor St Medical Center. Today, I'm going to talk about the percutaneous management of mitral and tricuspid valve disease. I have no disclosures. Talking about the mitral valve regurgitation, the prevalence is age-dependent, affecting almost 10% of the patients aging more than 75. The etiology is either primary or secondary. It's either a valvular pathology or a ventricular pathology. The excess mortality occurs from the medical management only and delays in the intervention. The surgical risk and the etiology determines the intervention and its timing. The delay in the surgical referral and the complexity of the valve pathology itself can increase the mortality. The rest of my slides will have multiple 3D images, and I want you to be familiarized with this. You can see in the primary, which is a valve pathology, you can see the aortic valve anteriorly at the 12 o'clock and the left atrial appendage at 9 o'clock at anterior septum. That's the anterior mitral leaflet there and the posterior mitral leaflet there. You can see a flail posterior mitral leaflet, the central scallops, causing the etiology of it. And here you have an annular dilatation because of the ventricular enlargement, causing tethering of the posterior mitral leaflet and mitral valve regurgitation. Moving on, we know that despite the patients have significant symptoms without qualifying for a class 1 indication, continuing medical management has detrimental effect versus the early surgery. And there are multiple percutaneous valve therapies currently available for patients who are at higher risk. The initial trial which led to this was the Everest-2, which is a 5-year follow-up data showing that though there is no significant difference between patients who are randomized for surgery versus edge-to-edge technique of mitral clip, there was a significant difference immediately after the 6 months period. So if the procedure is successful, if the mitral clip procedure is successful, there is no significant difference after 6 months in regards to the reoperation and the repeat mitral valve surgery. So that was led to the initial approval of a mitral clip for primary mitral valve insufficiency. Now this, as everyone knows, it's a co-op trial, which is mainly for the secondary MR, and it has shown almost a 36%, almost 50% reduction in hospitalization when compared to the patients who were treated just with medical management compared with medical management and device group. So there was 36% per patient year in the device group compared to 68% in patient year in the control group. And also the mortality was significantly differed in patients who was treated with device and medical management compared to medical management alone. And you can see here, the death from any cause within 24 hours was almost like 30%, even in the device group, compared to 46% in the control group. So despite optimal medical management and treating with a mitral clip device, 1 in 3 patients die, showing the higher risk of this patient population and whom we are actually doing it in a current clinical world. Going along, this is just a multiple transesophageal echo views to show how we get on to know where the pathology exists and how we are going to move forward to really treat this. These are all the color compare views of a 4-chamber, a 2-chamber, where the commissural views, and know where the pathology is. In this case, it's the posterior mitral leaflet. We use 3D essentially to know where the cleft mitral leaflets are, or where the flail segments are, to really know which direction we're going to place the clips. And this improvement in 3D technology has really improved our success rate with the mitral clips. Also, in doubt, we use the effective regurgitant orifice areas to calculate the severity of the mitral valve insufficiency, especially in the functional cases where the PISA is less useful given the concentric shape of the jet, and the EROA of more than 0.5 depicts to be severe. And in doubt, we use cardiac MRI to assess the severity of the mitral valve regurgitation. As a part of a pre-mitral clip planning, we want to know what the baseline mitral valve area is, and if the mitral valve area is more than 4, we're pretty comfortable that like placing a clip is not going to cause mitral stenosis. So we use the 3D multiplannar reconstruction to measure the area, and we'll make sure this is all amenable for mitral clip. This is a transseptal access video just to show that the optimal distance from the annulus is at least like 4 to 5 centimeters, because there is a limited talkability of the guide catheter. So we want to have as higher as possible, so we're not like ending up in trouble reaching the valve leaflet or like overreaching it. This is where we judge where exactly to place the clip. We look at it in multiple views, and once we are comfortable, we grab the leaflet, and once we show that like everything is fine, then we'll check it on the 3D from the atrial side, from the ventricular side, as in these top views, looking from the atrial and the ventricular aspect of things, and then we place the color to make sure that we had a good result of the mitral valve regurgitation. And this is the secondary MR case where, again, even though you have a very tethered thin posterior leaflet, we were able to grasp and cause a very good result. We would make sure that before releasing it, we want the mean gradients to be at least 4, in this case, just 1. So we're not like really causing any mitral valve stenosis after placing the clip. Now, there are multiple cases where the surgical the percutaneous edge-to-edge repair is not amenable, and they are still high risk because the surgery is not the option. I'll show some of the examples. And in this particular case, it's a mitral valve operation from the medial commissure, causing a significant jet going along the laterally and filling all the left atrial appendage, in fact. And here you can see how the perforation is rising from the commissure medially. In this case, it's pretty hard to have an edge-to-edge repair, obviously, and anatomical defects like cleft anteromitral leaflets, a significant deep ridges in the posterior mitral leaflets, and having a very wide prolapsing segment with multiple file claudes, especially in this particular case, with very severe mitral valve regurgitation. So to grasp all these cords and the leaflets can significantly undercure the disease and can cause stenosis with a very poor outcomes in the end. And in this case, is an elderly lady who has got Barlow's valve to start with, but she has continued to have significant valve stenosis with valve calcification with a fly-out segment right up there where the arrow is pointing out. In these particular cases, placing a mitral clip can cause mitral valve stenosis, and these are not an ideal cases for proceeding with edge-to-edge repair. This is another final example of papillary muscle rupture. Even though it's amenable for clipping, it's going to be a really difficult and a challenging case to proceed with it. In these cases, the newer percutaneous valve devices have been developed, which to completely replace the mitral valve with the new bioprosthetic valve. The multiple types have been developed. There are like a lot more to be shown. These are some of those examples. Now, many of these devices use a different mechanism for anchoring. Some uses the left ventricular apex, like a tandem valve, or some use the radial force, like Integrative valve, and some has the anchors around them to show these anchors are can give the support radial strength for the devices to sit on, and so on and so forth. And we currently have Apollo trial, which is an Integrative device from Edwards. It's a very elegant design with an outer ring which sits nicely into the complex annulus of the mitral valve, and there is an inner ring which contains a 27 millimeter tri-leaflet bioprosthetic pericardial valve, and it gives an elegant way of dealing with the complex annulus and then still having a decent orifice to overcome the mitral stenosis and paravalvular leaks. The study design is currently we have like a 1:1 randomization and a single arm itself, and this has further evolved into patients who also have mitral valve calcification, and now a current generation transseptal deployment has come up as well, which is going to revolutionize, which is going to completely revolutionize the current technique. This is an Intrepid TMVR system, which is an Apollo trial. Again, I want to show the animation of this, which is self-expandable. You can see once you unsheath the device, it's going to adhere to the annulus, the outer skirt, and takes the shape of the annulus, and then releases the inner device with no significant paravalvular leaks or like any major compression of the inner stent. So there's a lot of pre-procedural planning goes along with this cardiac, with the cardiac CTs to make sure that the device is right sizes and whatnot. And this is just to show the way to go with the septal lateral and the commissural to commissural distance and the area and the perimeter. We go with the 3 different sizes currently available for us to use, and we use one of them with a suitable with a suitable upsizing. This is an elegant way to show that in a baseline normal heart, you have an LVOT, which is the narrowest portion of the area in the outflow tract. And once you place the prosthetic device in B, you have now have a new narrowest portion, which is now called as a new LVOT, and that's the area of interest right now for any of the percutaneous devices to be placed, because you could lead to a significant narrowing of the LVOT, causing significant LVOT gradients. So the way we go across is we model the valve at different phases of the cardiac cycle, and we average the areas throughout the cardiac cycle. And if the average systolic area of more than or equal to 1.5 centimeters square, we're good to go and proceed with the valve deployment. This is just an example of an Intrepid valve going through transapical route. And once it goes to the center of the valve, we kind of like label so that like it's easier for the surgeons and interventionalists in the room to know where exactly the device is placed. And once it's placed, unsheathing the device will make it land right at the center, or anteroposteriorly and the laterally. And once we are comfortable, we'll go ahead and start unsheathing, and you can see this. The valve, the bioprosthetic valve, start to function, and in this case, with only trivial central leak and no significant leak. Also in the 3D, see the outer skirt sitting very nicely around it, and the inner stent showing a nice valve with a very trivial central mitral valve regurgitation. So what are we supposed to do with the valve in MAC? And this is an example of showing what happens when we do a modeled valve in the rings, which is a valve in valve or valve in a prior bioprosthetic valve. And you do have significant neo-LVOT reduction, and it's a concern. And as is the case with a native valve, where you have a decent neo-LVOT. But however, in patients with mitral valve stenosis, as you know, the LV is smaller in these cases. The neo LVOT is significantly smaller, and there is a higher risk in this patient population that this can lead to a very narrow LVOT, and LVOT gradients can occur. So the planning for these cases of the valve, the prosthetic percutaneous valve in the MAC is very challenging. This is the case where you can see there is a significant concreted mitral valve, which is a severe mitral valve calcification of the annulus, and then you also have a mitral valve stenosis. So you got to deal with this, and obviously the surgical risk is extremely high in these patients. Dealing with both the valves, and the pump time is going to be higher, and so is the risk of the surgery. And this is just to show a photorealistic lightning to enhance the 3D view and showing where exactly is the calcium, so the surgeons can really know, and the interventionists to predict the paravalvular leaks and the outcomes. So the previous case, which I was showing, we dealt with a TAVR core valve in her aortic valves, and then we modeled an Edwards sapien valve in the MAC, and we know that there will be significant issues with the paravalvular leaks given the extent of calcification and whatnot. So we proceed with a surgical, minimal invasive surgery where you have a direct deployment of the Edwards sapien valve, suturing and flipping and suturing the mitral valve around the Edwards sapien valve to overcome the paravalvular leaks with a very excellent result. And this is just an example at the baseline on the top, and the bottom showing you have an Edwards sapien valve within that MAC, and here an example of that with color. I mean, some reason it's not playing, but you would have a significantly lower risk of paravalvular leaks. In summary, initially you got to assess the morphology and determine the etiology of MR. When you have a doubt of MR, you need to get to a disproportionate MR to treat, and especially the functional MR cases. If in doubt, use cardiac MRI. The mitral clip is approved for both primary and secondary MR in patients with higher risk and not suitable for edge-to-edge repair. The newer percutaneous devices coming into way, and also don't forget that it's a complex pre-procedural planning with the multiple device sizing, prediction of complications, everything. And then in a very high risk patients with MAC, there are few centers which offers a minimally invasive hybrid TAVR and sapien valves in MAC. So evaluating tricuspid valve for interventions, and you can see the tricuspid valve is extremely complex, much more complex than the mitral valve. This is just an anatomical cross specimen showing the septal leaflet and the anterior leaflet and the posterior leaflets. And we're lucky enough to have a much developed 3D processing, giving us an anatomical view of how these leaflets appear and where they are situated and where the jet is originating for us to know. However, that's not enough with Dr. Han's recent publication showing there are multiple different subtypes of tricuspid valve, the majority being the classic type 1, having 3 leaflets, and then the type 2, which is like a bifid anterior and posterior leaflets. And the type 3 ABC are most interesting, where you have a deep ridge in the anterior, deep ridge in the posterior and septal, and then you have deep ridge in both anterior and posterior, further dividing the different valve morphologies. Majority of it, as we see, only 54% is the common tri-leaflet, and the remaining has much different complexity, the remaining 50%. So when we're dealing with this, we have to keep all of these morphologies in mind before moving forward for an edge-to-edge repair for the tricuspid valve. Once again, the majority of the tricuspid valve regurgitation is secondary to left side pathology, or because of the pulmonary hypertension more than 85% of the time. And the less common primary TRs are because of the rheumatic heart disease, myxomatous disease, absence anomaly, endocarditis, or because of the iatrogenic pacemaker leads and RV biopsies, etc. However, the pathological MR can itself remodel the mitral annular enlargement and RV remodeling. This is an example of showing like how the natural course of patients who has a heart failure with reduced EF, and this is just a mortality curve of the severity of the vena contracta, effective regurgitant orifice area and regurgitant volume over time. And then, and again, like, and showing that the survival probability of patients who has significant vena contracta area, effective regurgitant orifice area and regurgitant volume, the worse the parameters, the worse the mortality. RV is one of the most important aspect when you're dealing with a tricuspid valve, like the LV is for the mitral valve. And we always have a very keen interest on looking at the right ventricular size and function. In our valve clinics, this is like a routine for us for all of the valve cases, whether they're going for surgery or for percutaneous valve therapies. This is just an example of showing in patients with significant tricuspid valve regurgitation. At different stages of heart failure determines their outcomes, like stage 1 being normal RV function, stage 4 being a very severe reduced RV function, and showing the survival curves. So RV function is very important. Sometimes we tend to use cardiac MRI to precisely assess the RV size and function, so we know the reserve the patient has moving forward. So coming to the different tricuspid landscapes, there have been trials which are used to tackle the cooptation devices. The few which deal with suture annuloplasties and heterotropic valve, the cable valve implants, and the ring annuloplasties, and a direct transcatheter tricuspid valve replacements. We're not going to go through every single aspect of it. Let's just go with the tricuspid valve edge-to-edge repair. So we're fortunate that it's a right timing. The multiplanar reconstruction, with the live multiplanar reconstruction, came up with the 3D, so we can really understand better how and which valve leaflets are really involved, and zoom that valve up in a short axis to know the anterior septal and the posterior leaflet. And as I showed before, the complexity, to understand better the complexity of the tricuspid valve. And placing the color, we know between which leaflets that does the majority of the valve, the tricuspid valve regurgitation is originating. And currently we are part of a class TR trial with a Pascal device, and we plan in a way that where we should be placing these devices beforehand, and once we get in there, we'll plan accordingly to know whether we should place septal anterior and septal posterior leaflets for a better result. This is one of those cases we're dealing with that, like, you want to align them right and plane, and then when you get in there, you want to make sure that both the leaflets are right under the grasping areas. And once you plane it where you want to grasp, you got to make sure that both the leaflets are in the arms. And before we confirm that everything is in place, we'll make sure that there is a reduction of tricuspid valve regurgitation, and there is significant tethering of these leaflets, so we know that they are within the clips, and then we release the clip and look at the stability. Currently, anything more than less than moderate, we consider it as successful, and the patients are showing significant improvement in symptoms once we do even reduce it to a moderate. Moving forward to heterotropic caval valve implantation, again, CT plays an important role. We measure it right above the first hepatic vein, and we have like minimal upsizing of these ones. And once we know the exact position, we calculate the circumference and the area and select the device. These are some of the device, the trach valve, which is again showing nicely in the CT. The valve, the leaflets sit right at the RA-IVC junction, stopping the regurgitant flow back to the systemic organs. And then this is the sapien valve sitting right at the IVC-RA junction. This is a try and navigate valve, which is many of the trials were done. This is from the Cleveland Clinic. It's a direct deployment of the valve in the animal models, and we're waiting for the true human trials to come out. And this is an EVOQUE system, which is an adverse trial, which is currently been going on for much more complicated and a complex tricuspid valve morphologies, where it's difficult to do a edge-to-edge repair, and we're anticipating this trial to come to our center in due course. In summary, the tricuspid apparatus is much more complicated than mitral, and the secondary TR is almost more than 85%, and the medical management leads to higher mortality compared to treating these patients, there is a really high risk of isolated tricuspid valve surgeries, almost close to 10%, and this goes up to 30% if it's a radio surgery. The edge-to-edge technique is rapidly getting there. It's very popular, improving the symptoms of these complex patients, and the multiple transcatheter devices are in trials right now, and we hope for the best suitable tricuspid valve therapy to come up in due course to overcome the complexity of these diseases. Thank you so much for your time, and we're happy to take any questions, and thank you.